Thanks so much, Dr. Colvin and the interns and to other people at MGH for inviting me. This is, of course, a really fun topic or set of topics for me to talk about, DBT. So I want to cover a lot of ground today. What I want to start is, because not everybody is familiar with DBT, so I want to start by just describing it a little bit, and also talking a little bit about emotion dysregulation, which is really the core problem that we're treating in DBT, and how that facilitates our transdiagnostic thinking. I then want to give a fairly broad overview of treatment outcomes. What do we know about this treatment? For whom does it work, and what are the outcomes? And then I want to move quickly to talking about the processes of change. So DBT is established as the standard of care for treating not only borderline personality disorder, but also a set of multi-problem presentations that often include suicidality and self-harm. Why does it work? What's going on? What are some of the structures, components that make DBT work? What are some of the mediators and predictors? And then we'll wrap up with some closing thoughts and take some questions. So first, comprehensive DBT, as we think about it, actually is different from most psychotherapies. Most psychotherapies involve a one-on-one process, sometimes include some kind of other adjunctive work with parents or families or partners. But in DBT, there are actually 5 different functions of treatment, 5 different components, if you will, that go into a comprehensive DBT program. The first of these is skill training, teaching people psychological and social skills around attention, mindfulness, being able to tolerate distress instead of making things worse, managing or regulating their emotion, and becoming more interpersonally effective in managing their social relationships, and more, other skills as needed, including things like how to approach the world more dialectically. The second component is, at least structurally, like other psychotherapies, involving individual therapy, one-on-one, with a dialectical focus on acceptance and change. The word dialectical in DBT, in fact, predominantly focuses around this balance of acceptance and understanding on the one side, and on the other side, how to change things that are painful and reduce suffering. In individual therapy and DBT, the therapist and client work collaboratively, have very clear targets, which are, of course, the hallmark of any behavior therapy, but also add a very comprehensive system for understanding and validating the client's experience and to help the client learn to self-validate. This includes some pretty standard behavior therapy strategies, like trying to do an assessment of problems in a behavioral way. What's the chain? What are the steps that lead to certain problems, like maybe a suicide attempt or a substance use relapse, and then using the skills from number 1 to solve those problems. So individual therapy is the second and also obviously an important component of treatment. We also recognize that, that people have problems, not just the 1 hour a week that they're in treatment, or in the case of DBT, maybe the 3 or more hours a week they're in treatment, but actually can have difficulties doing new things, doing things better in between sessions. And so in DBT, there's coaching available to help people implement new skills in their life between sessions. That's in an outpatient setting, typically done by telephone or these days texting. In residential and inpatient programs, our floor staff, the people who are working on our units 24 hours a day, are trained in DBT skills and skills coaching. So people can get help to try something new, to do something different, to manage difficult situations, or situations that in the past might have led to a crisis. The fourth component has to do with the fact that our model in DBT is transactional, understanding that we live in a social world and that how we act affects other people and how they respond in turn affect us. And so helping people who have a lot of dysregulated emotions includes not only helping them manage their emotions better, but also helping people in their family environment and social environment respond to them in a different way. Turns out that this is not only good for the client, but it's also good for family members. And then lastly, the fifth component is an ongoing team consultation. The idea being that working with people with multi-problem presentations who are often suicidal or self-harming, using substances, sometimes engaging in other risky and impulsive behaviors, and honestly, who take longer than other kinds of problems to get better, that this can actually be stressful for treatment providers. And so consultation team to help therapists stay well regulated themselves, not burn out, maintain their well-being, and at the same time get better and better at delivering the treatment. This is an ongoing, regular, weekly part of the treatment. So when somebody refers to DBT that's comprehensive, they're including all 5 of these components. Sometimes you'll hear people talk about DBT and they'll only mean one of these components, like the person's getting DBT skill training, but perhaps another kind of individual therapy or no therapy at all. That's certainly a component of DBT, but is not to be confused with comprehensive DBT. And that distinction is important, and I'll come back to it later with some data. All right, so we're going to try to, in DBT, replace the fear of the unknown with more curiosity, or another way of thinking about mindfulness or awareness as the core skill. That being able to learn how to react in this moment instead of maybe to things that have happened in the past becomes an extremely effective way of moving forward. So DBT predominantly treats problems related to emotion dysregulation. And many of you probably think about dialectical behavior therapy as a frontline treatment for borderline personality disorder, and certainly that's true. And when DBT was developed by Dr. Marsha Linehan back in the 1980s and early 90s, the first set of problems that she designed DBT to treat were indeed suicidality in people that had borderline personality disorder. Since that time, however, DBT has expanded and has been shown to be extremely effective with problems that that may not necessarily be borderline in nature, but it definitely involve dysregulated emotion. So one way to think about it is that borderline personality disorder itself is a prototype for problems, for severe problems related to emotion dysregulation. And that, of course, people might have other problems related to emotion dysregulation, yet not carry a borderline diagnosis. So what is emotion dysregulation, and what are emotion dysregulation disorders? So the idea here is that people learn maladaptive behaviors. They're maladaptive because they're problematic in one way, but that they function to help people regulate their emotion. So if you think about this, the vast majority of people, when we do studies, and there are several studies behind this, for example, who self-harm or make suicide attempts, the immediate goal is the reduction of a very aversive emotional state, reduction of emotional suffering. And then, in fact, following self-harm or substance use or restricting eating or binging and purging or even punching somebody in the nose, that reduction in that aversive emotional state reinforces those behaviors. It's actually a maladaptive, in one way to regulate emotions. So of course in DBT, we're trying to teach people how to manage their emotions without those maladaptive strategies, to actually learn, frankly, just better strategies for managing their emotions. Of course, some maladaptive behaviors don't function that way. One of the hallmarks of borderline personality disorder, for example, is the fear of abandonment, that rejection sensitivity that's very common in BPD, but actually fairly common in other people too, even without a borderline diagnosis. So fears of abandonment, that doesn't help regulate emotion. In fact, those fears of abandonment are part of a dysregulated cycle, but they are the natural consequences of a person being chronically dysregulated, because they tend to get dysregulated, do impulsive and extreme things socially and in interpersonal relationships, sometimes burn those relationships out and then feel very abandoned. And that feeling of abandonment is then becomes a pervasive fear because they have in fact been abandoned many times. So all of these examples point to the heterogeneous nature of emotion dysregulation problems, even though you might think of borderline personality disorder as a kind of umbrella for many of them. One of the really important parts of emotion dysregulation is that it's transdiagnostic. Many of us think about transdiagnostic issues these days because our diagnostic system, such as it is, on the one hand, has value in terms of classifying people, which leads to hopefully more effective treatment. But the idea of diagnostic classification breaks down when people start to meet criteria for 2, 3, 4, or more disorders. It's very hard to think about mounting 2, 3, 4 different treatments for a set of problems. In DBT, because we understand these various diagnoses as all being connected to emotion dysregulation, we can provide one coherent treatment that addresses the various parts of these disorders. So for example, in this diagram, you can see emotion dysregulations in the middle, and there are double arrows going out to these satellite circles, which in this particular slide show you different problems that are common with people with chronic and severe emotion dysregulation, and also, honestly, overlapping quite a bit with our classification for borderline personality disorder. So the idea is that when somebody is dysregulated, really suffering from their emotion, they may engage in, say, impulsive behaviors, or engage in attempts to avoid situations, or frankly numb out their own emotions. So that's the 9 o'clock and the 10 o'clock on the clock here. But of course, when people engage in impulsive behaviors like, say, self-harm or aggression, or attempts to numb out like substance use, restricting eating, those things create further problems in life which further dysregulate the person, and so forth. I'm not going to go around all the satellite circles here, but you can see how each of these problems is both caused by severe and chronic emotion dysregulation, and in turn contributes back to and contributes to this pervasive emotion dysregulation in the person. So how does this develop? How does somebody end up being chronically emotionally dysregulated? Well, first we want to note that everybody gets dysregulated sometimes. Okay, so we're not going to leave the idea of emotion dysregulation as being something that's only present in people with various diagnostic problems. In fact, I'm assuming at some point everybody here has said something mean to someone that you love. Okay, everybody's, I assume, done that. That's the problem with doing this on Zoom. You can't raise your hands, I can't see you, but without having to go too far on a limb, I'm pretty sure that everybody who's listening has done this. So when we say something mean to someone we love, why would we call that dysregulated? Well, because it is in fact a behavior, that meanness, that sharp thing that we might say to someone we love, that actually doesn't advance our goals. At that moment, it might feel like the thing to do. But later on, we regret it. We wish we had said something different, had done something different. So the idea is that at a high state of negative emotional arousal, boom, we get dysregulated, we do something that actually briefly helps us feel better. But in the long term, of course, makes the relationship worse, which isn't what we want. That's what makes it a dysregulated moment. Now, you can think of emotion dysregulation on a continuum. Some people get dysregulated seldom, only occasionally. And there's plenty of time in between those dysregulated moments to repair relationships and repair mistakes and actually keep things in a pretty settled way in their life. All the way up to people who are chronically dysregulated, which means that they're going to get dysregulated multiple times every day. And then the fallout from those dysregulated emotions are often all kinds of actions that are regrettable, or not taking actions that would have been important that actually continue to make somebody's life pretty difficult and more miserable. So how does this happen? Well, here's a model for emotion dysregulation. Now this model, the first 4 steps of it could apply to any of us that might occasionally get dysregulated. So it starts with number 1, that green box. It says there's an event, something happens, and we're human beings. We have an emotion system as well as a cognitive system. And our emotion system gets peaked when something happens. So something happens and then we have an emotion. That's normal. The only thing that has to be true psychologically for us to have an emotion is that we have to discriminate, means our brain has to be sensitive to the fact that something happened. So this could be as simple as bumping into somebody you know in the grocery store, or it could be something that's more complicated, like somebody yelling at us and being mean to us in some way. So that's the emotional arousal. That's there. Now the second piece here, of course, is that our cognitive system can jump into place. Second or third, I'm going to jump to judgments. The third piece here is the judgments. That we might be judgmental, meaning right or wrong, good or bad, about the event or ourselves or another person, and that's going to contribute to further emotion. Notice that that arrow goes in both directions. That's because when our emotion gets big enough, our thinking becomes binary. Everything starts to look like a threat or not a threat. It's right or it's wrong. It's with me or against me. And that binary thinking, of course, that comes out of high enough emotion creates itself more negative emotion. So that's a cycle. We've known that since 1908, a rather famous series of experiments, something called the Yerkes-Dodds equation, that upside down U. The other piece here is that high emotion vulnerability box, number 2. And those vulnerabilities could be more temperamental, like how sensitive we are to emotional things, how reactive we are when emotion things happen, or how long does it take us to calm back down once we get upset. It could also be other biological factors can contribute to our vulnerability, like we haven't had enough sleep, or haven't been eating well, haven't had enough exercise, or we have a cold, or we have pain in our back, or we have a headache. All of those things make us more vulnerable to having a bigger emotional reaction. So if you think about it, a small event with a lot of vulnerability and plenty of judgments will create a lot of negative emotion. But even a large event without judgments and without too much vulnerability can create emotion, but emotion that's still relatively easy to manage. Now, many models stop there and they'll say, okay, if you get big enough in that box of heightened emotional arousal, you get dysregulated action like self-harm or suicide attempts, substance use, and so forth, or just problems in relationships like angry outbursts or social withdrawal. However, in this model, we want to go a little further, and we want to say that the person who's getting dysregulated at that point, living in a social world, is going to express him or herself in an inaccurate way, meaning that person is probably going to express things that are not accurate and don't help the person understand. So this is the case of your partner. I suspect everybody's had this occasionally. When you think that there's something going on, maybe your partner's not so happy, and you say, what's going on? You don't seem happy. And the person says, I'm fine. Well, that I'm fine is probably inaccurate expression. Now, it doesn't mean the person's dysregulated yet, but it does mean that that person's now even more vulnerable to getting dysregulated. The inaccurate expression could also be in the form of judgments. Well, this person's a jerk, or you're a jerk, or who knows what. Those things can be provocative to the person who's listening. Regardless, what happens is the other person, parent, a partner, another person, friend, teacher, doesn't matter, is now at great risk for invalidating the experience of the other person. Now, there are a couple of different ways to invalidate. One is what I would call more passive invalidation, which is just a failure to understand. If I don't understand that you're in pain, I might ask you to help me move a heavy object. Help me move the refrigerator. Because I ask how you're doing, you say you're fine. You don't tell me that your back is killing you. I say, hey, could you help me move this refrigerator? And that puts a big demand. That's actually kind of invalidating of your pain. That's passive. It's an easy thing to fix, but it's still invalidating. Or it could be more active invalidation. Like you tell me, gee, I don't want to help you move that, I've got a backache. I'll say, oh, come on, this is quick, it won't take long. Or it's not that big a deal. You don't have to lift it, you just have to push it. So in other words, I'm really saying your pain isn't a big deal. Okay. Now, of course, that's physical pain. It could be quite the same with emotional pain. It's really easy to invalidate things that we don't understand. And when the other person's vulnerabilities are different than ours, that person might be more sensitive emotionally or more reactive emotionally. It means that we're more likely to misunderstand. And if we don't understand, we're more likely to invalidate. But of course, the person who's doing the invalidating also has his or her own emotional arousal, his or her own judgments that will make that go up, and his or her own vulnerabilities that can contribute. So the person could even be accurate and get invalidated. But it's even more likely if the person's inaccurate, the invalidating person who's highly vulnerable and obvious and at him or herself has a lot of a negative emotion is much more likely to be invalidating. And of course, we all know that validating increases our positive emotion and invalidating invalidating decreases our positive emotion. Invalidation also increases negative, and validation decreases negative. What does that look like? Well, here's a study that Chad Schenk and I did a number of years ago. I won't go into the details, but we put people under, these are volunteers, ordinary sample of people, cross-section, and we stressed them out using some arithmetic problems that were too hard to solve. So it's a pretty simple stressor, but everybody got stressed out. The negative emotional arousal on this graph is represents psychophysiological arousal. We measured their skin conductance, their respiration, their vagal tone, as well as their self-report about their negative emotion. And the pattern was the same. So this is a condensed slide that represents all of those dependent variables. And as you can see, we stressed people out and they got stressed. They went from about a start of 13 up to about 20 on this scale. And what they didn't know was that the experimenter was either going to validate or invalidate them. They had been randomly assigned to have a validating or an invalidating person who's running this experiment. And as you can see, as they continue to get all of their arithmetic problems wrong, and 100% of the arithmetic problems they got the wrong answer to, over time, the people who got validated about their emotional experience, like, oh, it makes sense, this is stressful when queried, notice the green line, it comes down, 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 3/4 of the way down. So they could acclimate to this stressful situation if they were in fact validated, if their experience made sense. Whereas the red dotted line or dashed line, if they were invalidated, if the person said, well, it's not that big a deal, it's only an experiment, no reason to be upset about it, they couldn't acclimate. Their negative emotions stayed very high. This is very important has implications for psychotherapy in general. It certainly has implications for families, and it has implications for our current COVID-19 crisis, because in fact, we're all going through some of the same difficult things. And the more we can stay connected and validate each other, even though the stressors will continue indefinitely now for a while, we can tolerate those stressors and have less negative emotion about them if we can share them together and validate each other. Another example of the importance of validation, this is a sample of parents of clinic teens in the yellow and parents, a matched sample by age and demographics of non-clinic teens from the community. And as you can see, what we did is we videotaped them. They all knew they were being video recorded, of course. We video recorded them having ordinary conversations about the quality of their family life. And as you can see, the parents of the clinic teens were much less validating and much more invalidating than the parents of the non-clinic teens. And vice versa. The parents of the clinic teens, they were less validating than invalidating, and the parents of the non-clinic teens were more validating than invalidating. My guess is this is not a surprise to anybody, but it's important to see what this looks like. We've conducted a similar study with couples, with partners, and partners with a depressed partner, which actually look quite the same. So that leads us to number 4 here. And in number 4, the other source of arousal is, of course, being invalidated. And being invalidated raises emotional arousal and leads to further dysregulated behaviors. And those dysregulated behaviors themselves are often versions of inaccurate expression. Now, this particular model so far, these first 4 steps, this might apply to any of us. This might explain an argument that we had with a partner, or with a child, or with a parent, or with a coworker or a boss, and tell us how we ended up doing something perhaps impulsively, or just we ended up regretting down the road. The 5th step, of course, is that when those invalidating responses become pervasive, they become the norm, and there are many possible reasons for that. Those pervasive invalidating responses create a much higher level of vulnerability in the person. So getting invalidated sometimes is a common occurrence. I can't imagine anybody here today can't think of being invalidated, having been invalidated sometime, probably recently. Sorry about that. However, hopefully in between those invalidating episodes, there are plenty of episodes of being validated, being understood, having closeness, and having repairs. Okay, so the last thing about this model to remember is this is actually a DBT model. DBT interventions address every box and every arrow in this diagram. So another way of saying, gee, what is DBT doing? It's addressing all of these factors that lead to dysregulated emotion and dysregulated action. Now, so let me start with a summary of outcomes in DBT, and then I'll give some more particulars. So a couple of recent DBT meta-analyses and reviews have been consistent in finding that DBT results in not only less self-harm, but by aggregating many studies and lots of patients and clients over time, demonstrate actually fewer suicide attempts following treatment, as well as fewer deaths than all the treatments against which DBT has been compared. That's pretty important. So less self-harm, fewer suicide attempts, and fewer actual deaths. There's also ample data to talk about the reduction of significant other problems, things like depression, PTSD, substance use. So let's turn our attention there. Before we do, though, a side note. It turns out that providing DBT, which has all these components, these 5 functions of DBT, even though it's expensive to provide DBT, it only costs half as much as not providing DBT. That might be counterintuitive, but if you think about it, the cost savings here, 50%, and that's just during the treatment period, the cost savings accrues from significant reduction in dropout. DBT typically shows about half the dropout of other treatments. Significantly greater improvements in all these other areas, depression, anxiety, PTSD, so forth, as substance use, as well as less utilization of other services like psych ERs, inpatient days, and things that tend to be rather expensive, as well as increased employment at the end of treatment or shortly following the end of treatment. All of these things together show a 50% cost savings during the intervals of treatment. And then that 50% cost savings gets amplified in subsequent years because relapse rates are pretty small in DBT. We don't have an enormous revolving door. And so for every additional person who's not utilizing other expensive services and who's working saves an enormous amount of money to the larger system. Okay, so for whom is this relevant and for what problems? First of all, although DBT started back in the 80s as a treatment for adult women with BPD and suicide and or self-harm, it's subsequently been applied to both men and women, boys and girls, across the age span, including older adults. as well as adolescents in both outpatient and residential settings. Now, more recently, preteens, where there's, of course, a big emphasis on parent involvement. And a number of studies that include people with lower intellectual functioning with some success. And of course, because the importance of the transactional model to DBT, it's also been applied effectively with couples, parents, and families, almost always with multi-problem presentations. In fact, one way to summarize the data might be to say that the more severe and chronic the problems, the bigger the separation between DBT outcomes and other treatments. The more ordinary the problems, the less multi-problem presentations. DBT still works fine, but other treatments also work very well for those kinds of problems. Now, DBT has been applied in a variety of settings, and I've just thrown some references up here to give you a sense of the extensive nature of the database here. At this point, there are somewhere in excess of 50 controlled studies, literally hundreds of open trials, and other studies of DBT in a variety of settings. So DBT is clearly well established as an outpatient treatment, partial hospitalization or day treatment settings, inpatient and residential settings, and in forensic settings, both in the forensic settings and post either hospitalization or post discharge from prison for people on parole and so forth, including, by the way, a pretty varied demographic, including DBT for homeless people, as well as a wide range of demographics. So the database here is a pretty rich one. The problems treated, similarly, are all the things that show up as co-occurring problems in these multi-problem presentations. Pretty much everything that could be connected to emotion dysregulation. So, for example, we know that DBT is effective at treating borderline personality disorder. The average person going through DBT does not meet criteria for borderline personality disorder any longer at the end of treatment, and on follow-up continues to be free of BPD. Suicide attempts and suicidality, I've already mentioned. DBT shows comparatively superior results in reducing suicide attempts and suicidality, as well as non-suicidal self-harm. Depression. Again, now we're talking about multi-problem presentations of depression, not a typically a typical person who might present as depressed, but a person who's depressed with co-occurring other problems. PTSD. Interestingly, a significant proportion of people with BPD have PTSD. It's quite overrepresented in the BPD population. As some of you probably know, the definitions for complex PTSD in the DSM look an awful lot like the definition of borderline personality disorder, except for the requirement of having experienced trauma. Recent work by Martin Bohus and his colleagues in Germany has shown that using DBT to treat complex PTSD, so these are people who don't necessarily come with a borderline diagnosis, have been extremely successful. Work by Melanie Harnett and others here in the US have shown that this co-occurring severe PTSD with BPD can be successfully treated. So this is a whole relatively new avenue with very nice results. Many studies have demonstrated the effectiveness of DBT for binge eating disorder as well as bulimia. Not as effective with anorexia, but of course very little is effective with anorexia. And an emerging group of studies have shown that substance use problems and substance use disorders themselves are effectively treated in DBT. And almost all of these studies, when they measure social adjustment or interpersonal functioning, show significant improvements in that area. Significant reductions in anger and aggression, whether that co-occurs with BPD or not. And as I mentioned, very successful improvements in parenting, parent-child relationships, couples, and general family distress. I want to give you one example of a study, a randomized clinical trial that Jackie Pistorello, myself, and a bunch of colleagues conducted. We looked at 63 transitional youth. These are people aged 18 to 25, mixed males and females, all of whom had recent suicidality or NSSI and significant BPD presentations. They were randomly assigned either to a standard comprehensive DBT outpatient program or a BPD-specific psychodynamic psychotherapy treatment. We controlled for therapist expertise and the training of the therapists, supervision, contact hours. So clients in the psychodynamic treatment had as many contact hours. They had individual and group therapy in the same way that in DBT, we provide individual therapy and group skill training. The therapists in the psychodynamic treatment were available for coaching in between sessions, just as they are in DBT. And this treatment was provided for up to 12 months. All the assessments were done independently, blind assessors. So here are some results from that. Suicidality, I'm going to show you several slides that have the same format, where the red is the psychodynamic psychotherapy and the yellow is DBT. And as you can see, DBT shows superior outcomes at the end of treatment at 12 months and at the follow-up period, superior outcomes in terms of social adjustment problems going down. Depression, this is an interesting one, because if you think about Beck Depression Inventory scores in the 30s, actually the psychodynamic treatment did extremely well, and by benchmarks actually did better than many other treatments for this population, with mean scores toward the end of just over 15. But DBT again showed a superior outcome with ultimately their Beck scores down around 7 or 8. And also showed significantly greater reductions in family distress, despite, in this particular case, not having included family interventions, significant reductions in BPD itself. The psychodynamic treatment had about 3 criteria at the end of treatments, DBT about, on average, 1, and significantly more reductions in medication use. The psychodynamic treatment folks were about more than 50% were on psychiatric medications after treatment, and less than 10% of the DBT sample was. This is important because one of the alternative hypotheses for DBT's effectiveness could be that it helps people stay in treatment, reduce dropout, which helps them perhaps make better utilization of their medicine. And while that might be possible early in treatment, at the end of treatment, since more than 90% of folks are not on psychiatric medications, it likely has to do with the psychosocial components of treatment instead. So to summarize, these outcomes are consistent across dozens and dozens, more than 50 controlled studies. And as we start to move our attention to implementation studies, we're finding similar results across those places. One example is Daniel Flynn and colleagues study, where they've rolled DBT out across every catchment area in the entire country of Ireland, and have measured outcomes there and have showed significant improvements in their outcomes. And there are a bunch of other studies showing similar kinds of results. Okay, so what is it? What's responsible for the process of change? This is, of course, a big question. One possibility is the structure. Comprehensive DBT has a bunch of functions. Does it work? Do you have to have all the functions? Well, a number of studies have now looked at DBT skills only and have found that DBT skills only can be very effective compared to weightless controls or possibly other modest interventions. And that is absolutely true. However, so far, all studies but one have shown that comprehensive DBT has better outcomes than offering less than comprehensive DBT. And that one, even there, ultimately showed some better functioning down the road after the end of treatment. Fidelity to treatment is also important. It turns out that if we look at therapists in DBT who are not quite at therapeutic standards for adherence versus those who are, but in the modest range versus experts, that actually there are enormous differences in outcome, even within DBT, which is pretty important to recognize. So for example, people, the subsequent suicide attempt rate for people not quite at standard is almost 4 subsequent suicide attempts during a follow-up period, compared to 2.5 for people doing DBT moderately well, and drops down below 2 for expert DBT, for those who are truly adhering to the treatment. So doing the treatment well turns out to be pretty important. There are also certain in-session specifics that might be important. For example, dialectics, or the therapist's ability to balance acceptance and change, to validate emotion in specific ways. We need more in-session studies to understand this. And of course, family interventions might have something to do with the process of change as well. So I want to show you a study that Payne and I have done, where we've randomly assigned people whose kids are in intensive residential care to either get right away or delay involvement in an intensive parent skill program. As you can see, what happens is those who got the parent skills, which are green, they show significantly improved validation from pre to post. This is just over the course of a month. And they show significantly reduced invalidating responses just over the course of the month. But we didn't withhold, of course, the parent skill intensive from everybody. We just delayed them. Some people got it right away. Some people got it a month later. So when you lump them all together, by the end of treatment, we can see that those who received the parent skills, the green, showed significant, their kids reported much improved parents' emotional availability than did the kids whose parents didn't participate. This isn't randomized because the parents who didn't participate were not participating either due to logistical reasons or other things that got in the way for them. What happened to the teens? Well, improvements in parent validating and invalidating responses, more validating, less invalidating, resulted in significantly greater improvements at discharge in emotion regulation and in depression, in pretty significantly large effects. So this is good news. Intervening with parents not only is good for the parents, it's also good for their kids. It has salutary impact on their outcomes. What about predictors and mediators of change? Well, one consistent finding is that DBT is most effective in part because it's very good at reducing emotion dysregulation, which supports the transactional model and suggests it as a mediator. That in fact, other treatments, however they do it, that also result in reduced emotion dysregulation are also going to have good outcomes. The acquisition of DBT skills is associated with good outcomes. A couple of studies have now shown that. And specific types of validating responses that therapists do that help clients learn to discriminate between different types of emotion has also been shown to predict outcomes. And finally, back to families again, improvements in family functioning. So family functioning turns out to be a mediator of outcome. Again, back to our young adult study, DBT compared to psychodynamic treatment, family functioning mediated outcomes, meaning that for lumping them all together, all the patients, both conditions, and then first entering which treatment they got, and then seeing, okay, do improvements in family functioning actually predict outcomes? Early improvements for later. So this, using a hierarchical linear modeling and satisfying all the standard requirements for mediational analyses, that in fact, family functioning improvements mediated outcomes for suicidality and social adjustment. Pretty important, pretty interesting. Suggests that DBT inclusion with families is important as both a structural component, but also as part of the process of change. One of the things that makes this tricky is that parents can be deeply affected by their children's suicide attempts and self-harm. And in fact, we found that 432 parents who participated, not a random sample, so you have to be careful with these numbers, but nearly all of them reported intense fear, helplessness, or horror in response to that suicidality, and more than 95% could be classified with acute stress disorder, and almost half met criteria for PTSD. Keeping that in mind, interventions with parents might be important for a variety of reasons. So that's what we've been doing. So a DBT family skills program in the community that we call Family Connections has been around for a long time. We have good data from them. And when we do it in the clinic, we call it a DBT family skills program. The idea is to help parents and their kids do things differently, not keep this escalating emotion dysregulation cycle going. So in summary, what these outcomes look like, here's just from one study, from a study that Perry Hoffman and I and colleagues conducted a couple of studies with a replication a long time ago. Grief in the parents went down. All of these are significant improvements from pre to post and into the follow-up period. The program itself is 12 sessions long, and the follow-up period is about 3 months. Significant reductions in grief, significant reductions in distress and depression, significant reductions in burden. Parents whose kids are suicidal, as you can imagine, feel a profound sense of burden. And improvements in parents' experience of mastery and empowerment over this same period of time. I do want to note that even during the post-intervention and follow-up period, that these are not yet in the normal range because their kids are, of course, still suffering. However, even with the ongoing stressors of having teenagers and young adults, children who are struggling, the parents are still doing considerably better. So our conclusion here is clearly to include interventions with parents and family members as often as possible, with significant benefits to everybody. All right, where do we go from here? Well, clearly we have to balance this need for fidelity. If doing better and better DBT has better and better outcomes, that's great, but that's also becomes more rarefied. It makes it harder and harder to provide treatment to the very large number of people who need it. So we've got to find ways to balance that. We need a lot more research on the process of change, because the few studies that have been done have pointed that there, even inside DBT, there may be key things that therapists are doing that are clearly adhering, but it might be better or worse in some circumstances to get good outcomes. So we need these detailed in-session analyses. And clearly it's going to be helpful to work on prevention and early intervention. It's hard enough to treat people once they get to the point where their lives are really difficult and they're profoundly suffering. So one of these is something called the GAP Initiative, the Global Alliance for Prevention and Early Intervention for Borderline Personality Disorder, which is trying to help people who are in non-mental health roles like pediatricians, school counselors, teachers, and others identify early signs and refer for help. And of course, providing secondary prevention interventions with parents and families is another avenue that we can go. Okay, so I want to say thank you. We have about 10 minutes left for some questions. Okay, thanks for your attention.
Thank you so much for that excellent summary of emotional dysregulation and how DBT can be effective and for different, across different populations and different kinds of groups. We do have a few minutes for questions. If you'd like to ask a question, please feel free to type it into the chat box. I might give everybody just a minute to do so, or you can raise your hand and I will call on you as well. It always takes a few minutes to get the messages typed in. While we may be waiting, I was interested in the work that you have been doing to disseminate DBT and to distill it down so that it's applicable to different kinds of populations, and was wondering if you could speak to that for a minute.
I'm sorry, you dropped out a little bit there. Could you say that?
Oh, I did.
I'm sorry.
Oh, good. Actually, some questions just came in. Can you hear me okay?
I can now, yes, just fine.
Good. Okay. This is a question from Dr. Meyer, who asks, within the research that you conducted on parent responses to dysregulated versus community control adolescents, can you please explain how you measured invalidation among parents of clinic versus non-clinic teens? Thank you for a wonderful and informative talk.
Oh, well, thank you. Yes, we actually developed an observational rating scale, which is actually pretty easy for people to learn. It's reliable, where blind observers, we video recorded the conversations, and people who didn't know anything about the families, didn't know what the study was even about, didn't know whether they were clinic families or community families, that we have a rating scale. They could rate the parents in terms of how validating or invalidating they are. More recently, we've actually developed a self-report measure that people can write about how validating or invalidated they experience their parent or their partner, which seems to correlate fairly well to the observational scale, and it's a heck of a lot easier to use.
Thank you. This is a question about how you determine the experience of a DBT therapist.
The what experience of a DBT therapist?
The experience of a DBT therapist, how you kind of characterize that and capture it.
Oh boy, that's a big question. I think that it's somewhat varied. DBT therapists work in a lot of different settings and with a lot of different populations. And I think DBT, just like any treatment, people will gravitate toward a treatment that feels really good to them and will probably gravitate away from treatments that don't feel so. So typically, I think we do know that the ratings of burnout in DBT therapists they go down. We have, our group has, and others have published a couple of studies looking at stress in DBT therapists versus other therapies. The consultation team in DBT seems to provide an important avenue for burnout reduction and staying effective. I'm not sure I'm answering the question, but
I think that's great. There are a couple of questions related to creating programs for families. And I think, one question is how to create a comprehensive program for families that's similar to the comprehensive program for individuals. And if you could speak a little bit to the research related to DBT and being used in families. And I think I'll hold there. There's a second part to it.
Yeah, well, this is a great question. We've done a number of different approaches because different settings require different things. So, for example, in residential and inpatient settings, it's very hard to have multi-family groups, which include, say, teens or young adults and their parents, or multi-family groups that include partners, because they're in residential and they have groups every day, and their parents or partners aren't available every day. Whereas in outpatient DBT settings, having a multifamily group where parents participate with their teens, it's typically for adolescents, do so on a weekly basis. So we've developed these 2-day intensive programs for parents or for partners where we teach them a lot of skills. Some other folks have experimented with those parameters. So for example, some colleagues in Sweden have taken our two-day intensive program and tried to stretch it out over a series of weekends, so that in a residential setting, so that parents and partners, and they have a mixed kind of patient population, would come for a Saturday and then come back again 2 weeks or 4 weeks later for another Saturday, and so forth. So I think there's a lot of flexibility. Those tend to be skill focused on skills that parents and partners and other family members need to help our own emotions, manage our own emotions, but also to learn how to be less judgmental, less critical, less blaming, more validating of the other people, but also how to get more validation and how to receive fewer criticisms ourselves. We've also have good data now with doing family work, the couples therapy or family therapy from a DBT perspective, which is more like ordinary couples therapy or family therapy, one family at a time, one couple at a time, but weaves skills into the therapy process. And so we've developed a number of different intervention strategies to fit different settings.
That's great. And this is actually probably a good follow-on point. There's a question about studies looking at families and identifying predictors or mediators to parents' rates of burnout and depression. So
the predictors of, well, the single biggest predictor, of course, is ongoing dangerousness on the part of their children. And by the way, I would say this extends to couples as well. having a partner who's suicidal or has made a suicide attempt, or there's a lot more research, obviously, having a substance using partner. That's very stressful on a relationship and with each other. Parents and kids, it's the same thing. So having a partner or a child engage in dangerous activities is one of the biggest predictors. We also looked at just a sense of burden, because caregiver burden is a big deal when you have a family member, a child or a partner or a sibling or somebody else who's really struggling with their mental health and suffering in a big way. It also presents in our system often financial burdens to people, because I've worked with, I can't count the number of families I've worked with who are essentially bankrupt because the bills they have to pay for cycling through multiple hospitalizations, and their kid or their partner is not getting better. No criticism of those mental health systems. It's just that's a mental health treatment, but the system doesn't support them very well. So there are a lot of stressors for parents and partners. That those are the things that predict them not doing well. Of course, then they can exacerbate those difficulties by starting to do things themselves that aren't so healthy, not take care of themselves, not eat well, not sleep well, turn to substances, withdraw from social support, a variety of activities that can make things worse.
Wonderful. Well, there are actually a whole slew of wonderful questions that unfortunately I'm not going to be able to get to today, given the time. I do hope you can see, in lieu of the clapping, there are so many comments in the chats about how wonderful this talk was. It was an excellent overview, and I think really great for all of us who are interested in the topic. So there's a little bit of clapping. Thank you so much for joining us. Thank you to everybody who was able to join in, and be well.
Thanks so much. I really appreciate being invited, and this was fun for me. I hope it's been fun for you, and I will read all the questions and comments.
Thank you, Dr. Fruzzetti.
Okay. Stay well, be healthy.